Hello, my name is Courtney Graff, and today during my TED Talk, we are going to discuss Guillain-Barré syndrome. Guillain-Barré syndrome, or GBS, is an acute immune-mediated disorder of the peripheral nervous system characterized by rapidly progressive weakness, diminished or absent reflexes, and varying degrees of sensory and autonomic dysfunction. It is considered a neurologic emergency because of its potential to progress quickly to respiratory failure and life-threatening autonomic instability. Guillain-Barré syndrome is unique among neurological disorders because it develops suddenly, often in previous healthy individuals, and evolves over days to weeks rather than months or years. While it is rare, it remains the most common cause of acute flaccid paralysis worldwide, replacing poliomyelitis in most regions. Early recognition is critical as prompt treatment can significantly reduce morbidity and improve long-term recovery. The etiology of Guillain-Barré syndrome is most often post-infectious. In approximately 2/3 of patients, symptoms are preceded by an infectious illness occurring 1 to 4 weeks prior to the neurological onset of symptoms. The strongest association is with the Campylobacter jejuni, a gram-negative bacterium that causes gastrointestinal illness. Certain strains of the Campylobacter possess surface antigens that closely resemble components of the peripheral nerve myelin and anaxal membranes. This similarity leads to molecular mimicry in which antibodies generate to fight the infection mistakenly attack the nervous system. Other infectious triggers include the cytomegalovirus, which is often associated with prominent sensory symptoms, the Epstein-Barr virus, influenza virus, Mycoplasma pneumoniae, Zika virus, which has been linked to outbreaks of GBS globally. Vaccinations have been rarely associated with Guillain-Barré syndrome, but the risk is extremely low and significantly outweighed by the benefits of immunization. Importantly, most patients do not have an identifiable trigger, reinforcing the need for high clinical suspicion. Guillain-Barré syndrome has an annual incidence of approximately 1 to 2 cases per 100,000 people, making it a rare disorder, yet one with substantial healthcare impact. Incidence increases with age, and males are affected slightly more often than females. Although Guillain-Barré syndrome can occur at any age, older adults tend to experience more severe disease, longer hospital stays, and slower recovery. Children often recover more completely but may still require intensive care during the acute phase. Despite advances in supportive and immunomodulatory therapy, Guillain-Barré syndrome continues to carry a mortality rate of 3 to 7%, primarily due to respiratory failure, cardiac arrhythmias, and complications of prolonged immobility. Long-term disability occurs in up to 20% of patients, emphasizing the importance of early diagnosis and rehabilitation. The central mechanism of Guillain-Barré syndrome is immune-mediated peripheral nerve injury. Following exposure to an infectious trigger, the immune system produces antibodies that cross-react with antigens on peripheral nerves. The most common subtype in North America and Europe is acute inflammatory demyelinating polyneuropathy, also known as AIDP. In AIDP, immune cells attack the myelin sheath, disrupting salutary conduction and slowing nerve impulses. In axonal variants, such as acute motor axonal neuropathy and acute motor sensory axonal neuropathy, antibodies target the axonal membrane itself. These forms are often more severe, associated with rapid progression and prolonged recovery. As nerve conduction fails, motor signals cannot reach skeletal muscles, sensory signals become distorted, and autonomic fibers are affected. This explains the hallmark features of Guillain-Barré syndrome of ascending weakness, areflexia, sensory changes, and autonomic dysfunction. Involvement of the phrenic nerve and intercostal muscles can lead to respiratory failure, making pulmonary monitoring essential. A careful history exam is essential for early identification of Guillain-Barré syndrome. We as providers should focus on timeline, progression, and symmetry of symptoms. Key questions we ask our patients include: have you had a recent illness, such as diarrhea or a respiratory infection? When did weakness begin, and is it progressing daily? Did symptoms start in the feet or legs and move upward? Are you experiencing tingling, numbness, or a burning sensation? Do you have difficulty climbing stairs, standing from a seated position, swallowing, or breathing? Have you noticed facial weakness or changes in voice? Rapid progression over days with symmetric weakness strongly suggests Guillain-Barré syndrome and warrants immediate referral or hospitalization. While conducting our patient intake and we're moving on to our physical examination findings. Physical examination typically reveals symmetric flaccid weakness beginning in the lower extremities and ascending proximally. Reflexes are diminished or absent even early in the disease course. Additional findings we may see include mild sensory loss despite significant weakness, cranial nerve involvement, particularly facial nerve palsy, bulbar weakness causing dysarthria or dysphagia, autonomic instability, which can be characterized by tachycardia or bradycardia, blood pressure fluctuations, diaphoresis, or urinary retention. Mental status and cognition remain intact, which helps us differentiate Guillain-Barré syndrome from central nervous system pathology. A diagnosis of Guillain-Barré syndrome is primarily clinical, supported by ancillary testing. A lumbar puncture typically reveals albuminocytologic dissociation characterized by elevated cerebrospinal fluid protein with a normal or mildly elevated white blood cell count. This finding may be absent early and develops after the first week of symptoms. Nerve conduction studies demonstrate demyelination or axonal injury, including slow conduction velocity and prolonged distal latencies. Pulmonary monitoring is critical, which we would view forced vital capacity and negative inspiratory force. A declining forced vital capacity signals impending respiratory failure and the need for ventilatory support. Guillain-Barré syndrome can result in serious complications including respiratory failure, cardiac arrhythmias, aspiration pneumonia, deep vein thrombosis, pressure injuries from prolonged immobility, and chronic neuropathic pain. Psychological complications such as anxiety, depression, and post-traumatic stress are also common and often under-recognized. Management of Guillain-Barré syndrome requires hospital admission, often to an intensive care unit. The first-line immunotherapy includes intravenous immunoglobulin IVIG therapy or plasmapheresis. Plasmapheresis is used in Guillain-Barré syndrome because GBS is an antibody-mediated autoimmune disease. The goal of treatment is to remove the circulating immune factors that are actively damaging peripheral nerves. During plasma exchange, a patient's blood is circulated through a machine that separates plasma from blood cells. The plasma is discarded and replaced with albumin or donor plasma. This process removes the autoantibodies, complement proteins, pro-inflammatory cytokines, and immune complexes. By reducing circulating immune modulators, ongoing nerve damage is slowed or stopped. Plasmapheresis is most effective when started within 7 days of symptom onset and ideally within the first 2 weeks. Both IVIG and plasmapheresis are equally effective and should be initiated as soon as possible. Combining therapies does not improve outcomes, and corticosteroids were found to be ineffective. Supportive care is equally crucial when monitoring patients with Guillain-Barré syndrome. Continuous respiratory monitoring, DVT prophylaxis, nutritional support, pain management, and early physical and occupational therapy. Recovery occurs gradually over weeks to months as remyelination and axonal regeneration take place. To summarize, Guillain-Barré syndrome reminds us how quickly the balance between health and illness can change. A condition that begins with a simple infection can rapidly evolve into a life-threatening neuromuscular failure if not recognized early. Understanding the immune-mediated nature of Guillain-Barré syndrome allows providers to act decisively, initiating therapy such as plasmapheresis or IVIG, closely monitoring respiratory function, and preventing devastating complications. While the onset of Guillain-Barré syndrome is often sudden and frightening, early diagnosis, evidence-based treatment, and comprehensive supportive care offers patients the opportunity for meaningful recovery and restorative function. Awareness, vigilance, and timely intervention truly make a difference. Thank you for coming to my TED Talk on Guillain-Barré syndrome.